Good evening and welcome. It's now 6 o'clock. I'm handing over to tonight's facilitator, Dr. Nkube. Dr. Nkube, over to you. Dr. Nkube, over to you. Plengi. Dr. Nkube, you can take it away. Thank you. Maybe he's having some technical difficulty. Let's give him a couple of minutes.
Yes, thank you. Yes, so we're having a challenge with Dr. Luviobayeni joining. Can I just attend to that so that we can start? Thank you. Hi, Rainer.
Dr. Nkube, maybe you can start this session and then let Naleen contact Dr. Muketsi and Dr. Bayeni and see if she can get them online.
Okay, that's perfect.
Dr. Bayan is online though.
Oh, Dr. Bayeni is here. So we're just waiting for Dr. Mokete, which is fine. Thank you. Thank you so much. And thank you for your patience. And thank you so much for your patience. Welcome to our webinar series, which is Policy Dialogues for Human Resources for Health. You'll be aware we have had chronic challenges as a country in relation to human resources for health. And these have come up with lots of paradoxes where we have massive staff shortages in our healthcare facilities, accompanied as well on the outside by an increased number of unemployed doctors. We've had quite some pleasant discussions, some even informally with the Department of Health, with Dr. Bayeni, over the years when he started recently about a year back, and we've spoken about some of these policies and the importance of reviewing the outdated policies. And after that, we did see this year a report from the Auditor General, which was highlighting some challenges as well in terms of the overtime that doctors have been working, adherence to policies in terms of the hours that doctors work, as well as a lot of other policy issues that were raised. This resulted in a Ministerial Advisory Committee being set up by the current Minister of Health, Dr. Aaron Motsoaledi, who has then requested the committee to review policies on commuted overtime, on RWOPS, on community service, as well as rural allowance. You'll be aware, of course, of the statements that were made in Parliament about some of these policies, especially when it comes to community services, which really trended as a discussion in the parliamentary committee for portfolio committee for health. And so our objective here now is to say, as the largest medical grouping in the country, we need to give your voice to the Ministerial Advisory Committee as to how you feel, how you are experiencing the present policies, and what you feel needs to be done in order to improve the human resources for health policies. And to do that, we're starting off by giving you quite some information, very objective, independent information that is evidence-based. The research was done by Professor Mabunda, as well as some of his colleagues, and he'll be telling us about some of the things that they've seen globally as well as locally in terms of the structuring of the working hours that doctors have worked. So Prof. Mabunda is himself a medical doctor. He also holds a PhD in public health, and he's dedicated his career to resolving challenges in human resources for health, especially where there is skills shortage, where there is skills shortages and in underserved areas. I will hand over at this point to Prof. Mabunda to enlighten us with these insights that he has developed over the years. Thank you. Prof. Mabunda.
Thank you, Chair, for the kind introduction. I will just get my slides going, and then I will get my video on. So, are you able to see my slides?
Not yet, Prof.
Okay.
Just click on the button that says start sharing.
Yeah, that's where I am, but then I think I'm sharing the wrong screen.
Okay.
Sorry, I'll get it going. That's fine. I will need to be on the right screen. Let me undo. Let's try.
It's coming up on this slide.
Yeah, but it's the wrong screen still. Sorry, I've got multiple
Okay.
screens, so I need to get the right screen going. So let me start again. Stop the screens around. Apologies for that.
There you go.
Sorry.
We can see
Okay,
it.
are you able to see the first slide?
Yes, we can see it. Thank you.
Okay, thank you. Okay. Now we need to find the correct thing. Sorry about that. Okay, evening colleagues. Sikhumbuzo Mabunda is my name. Firstly, I have to acknowledge the presence of everyone here. Starting off by acknowledging the original owners of the land on which our university and hospitals are built. Also paying my respects to past, current, and future leaders present here today. It's an honor for me to be among you colleagues. I acknowledge the presence of our leadership in the form of the Department of Health and leadership of SAMA, and also colleagues as doctors and other academics as well. It's an honor for me to be presenting for SAMA members because it is one organization that contributed immensely to my professional life. I, at some stage, was on that side as well, and served and was given the task of negotiating for the occupation-specific dispensation in 2009. So that is why I feel honored to be back here again after so many years. Really, today we are not going to be innovating anything new. It's been done for years, you know, in this country and across the world. But then most of the presentation is going to focus on what has been done within the country and presented even, you know, in Parliament and other spaces. We will look, you know, at planning and its importance in everything that we do. Human resource for health, I mean, you might think it's a very simple thing. It's a very complex subject on its own. It consumes about 70% of budgets, of health budgets at least, you know. And you need to be able to then, you know, appreciate the complexities. To try and make it a bit less complex, I'm going to use examples, you know, to break it down, and examples that some of you might relate with before we can then answer the exact question that, the specific question that I was asked to look at on the policies that we need to look at and the hours of work of medical doctors. As you might appreciate, human resource for health is only one of 6 of the components of a health system. To some of us, we look at it as the engine of the health system, without which, you know, you do not have a health system. At the same time, being a system, it means that you need to work on all the components at the same time. You can't just, you know, focus on one. But then we look at it in that way, that it's a component of a system, and the system needs to be actually addressed as a whole. my work, in human resource for health spans around 20 years, really. This particular systematic review in display now is one of the works that looked at interventions for increasing the proportions of health professionals practicing in rural and underserved areas. That started off in 2005. And then we looked for all literature. This is a Cochrane systematic review. That is the highest form of evidence, really. And in this space, we wanted to look at what interventions have been used across the world. We couldn't find any in 2009 that have actually worked. And then in 2015, we only found one in Taiwan. So the four predominant, strategies that I used, regulatory, such as compulsory community service, for instance, that is one of the regulatory mechanisms. Personal and professional support, that could, for instance, be the accommodation that is given to colleagues. It could be housing. It could be housing. I've already mentioned that. It could also be, support for furthering your studies as a professional. Educational strategies that could be government taking you for studies, hoping that you will return in service, but that is also an incentive as well, financial incentive, but also non-financial incentives as well. There have been several, challenges that were described. I mean, if you look at this article in the Health Review by Smith et al., it says South African challenges really can be summed up in four. It's poor HRH planning being the biggest and the highest order of the problems that we have in the country. Then everything else follows that. Including the fact that there is maldistribution of health professionals between the private and public sector, but also geographic, rural, urban disparities as well. Now, in a question written for Parliament in 2019, the Minister of Health was specifically asked, what are the reasons really that there are challenges, in the recruitment and employment of health professionals. And then, the response by the minister then was that the budget has not been increasing over time. There is as well an increasing demand for health services that results from immigration and an increasing burden of disease. And that has been, at the time, the minister said, it had been for about 10 years already. A question then is there evidence for the policies that we have in the country? Or because often when you speak to South Africans, we pride ourselves with having the so-called the best constitution in the world. We pride ourselves with having good policies, but that are not then implemented well. But then is that really true? Or which would suggest that the problem is the implementation that is a problem. But the argument for some of the evidence that is there is that actually it's both problems. And at times even founding the policies themselves and the way they're formulated is the problem. They're not mostly based on evidence, which results in them cracking further down the line, which is what I will present in a way today, to then lead to answering the questions that we actually asked to answer today. So I'm going to use an example of research that we did for about 4 years, covering Eswatini, South Africa, Lesotho, and Botswana, looking at return of service agreements. Now, what are return of service agreements? You all, I'm sure, know what return of service agreements are, but then it's a fancy way of saying bursaries and scholarships. So these are schemes where future health professionals are funded to study towards a health profession. contracted often on a year-for-year basis to serve a specific area and return. And an underlying specific is not always specific in that contracting. One example that we know is the Nelson Mandela Fidel Castro medical collaboration, and then others as well, where people are studying locally. The primary objective is to increase the pool of skilled health professionals for a defined period. At least you show you've got individuals committed for the time, 6 years, 4 years, whatever, however long you funded the individuals for. And then the secondary objective is to increase that pool of skilled health professionals beyond that contracted period, because you're hoping then that once they fulfill their primary contractual obligation, they will then stay beyond that contractual period. So we look through this in 4 ways. Firstly, we looked at literature, what literature said about these policies and their history as well. Where they came from. When was the first policy actually introduced within South Africa, given South Africa's history as well, and then looked at Hansard's parliamentary Hansard's and also documents that could have founded this. But at the same time, also we interviewed for South Africa, for instance, we interviewed policymakers from all the 9 provinces to find out really what is their understanding, firstly on how the policies were formulated and founded, if the policies had been evaluated, what the objectives of the policies are, what are the measures of success which would result in termination of the policies. Which I will come to later on, because really with any policy that you formulate, you need to know what will trigger you actually terminating that policy as a measure of success, that you've actually achieved what you said to achieve with that policy. And then at the same time, looked at what the policymakers' perspectives are on what is resulting in successes and failures of these policies, and how they could actually be done differently or implemented differently. We also had a retrospective core study for an 11-year period, spanning from 2000 to 2010, looking at individuals who would have been funded at any stage during that 2000 to 2010 period. But that then indirectly meant that the cohort is more than 11 years, because an individual could well have been funded for a year in 2000, for instance, but then they began their studies before then, and they then, or even the funding would have began before then, and then we'll follow up those individuals to see where in the system they worked after completion of their studies, if they fulfilled their contractual obligation, and also looked at the enrollment time when they enrolled into the scheme itself, what actually decisions informed them being admitted into the scheme. All in all, the criteria that actually said this individual qualifies to actually receive a bursary or scholarship, and then also compare with the set criteria that would have been there, and at the same time then look at how long they stay in service, where exactly they work, and how many of them then fulfill their contractual obligations as well. As I said earlier, in South Africa, we looked at all the provincial health ministries. For provinces like Mpumalanga, where partially the scheme is managed by the Department of Education, we looked at that as well, and then Northwest, Office of the Premier, same as the Free State as well. Botswana, Lesotho, and Eswatini have different arrangements altogether. Now, when we then looked at what the objectives were, they said, well, really, we continued with what was there, as a government, a democratic government. We inherited a system that already had bursaries in the homelands, and then we just continued what was there. But then these schemes are there to address critical skills shortages. They respond really to the needs of the country in terms of the social needs, and also individuals from disadvantaged groups. and then complying with legislations as well. And then political reasons. One such example was the Nelson Mandela Fidel Castro medical collaboration, because the then President Nelson Mandela was involved in the signing of that agreement. And also to reward academic excellence. That was at least a belief of some of the policymakers. But then the challenge was that, again, stated by the policymakers themselves, the concern was, these documents, that were used to found these policies or inform the evolution of these policies over time cannot be found in many instances because they're not archived well. The origins are not known for South Africa as to what year the first policy, for instance, was introduced. And then has been in existence, at least, because the earliest we could find for South Africa, for instance, was searching through literally all prints of the South African Medical Journal. I'm glad I'm presenting to Sama. South African Medical Journal articles archived from 1884. Looked at every single one of those publications to find manually to find anything that actually suggests the first advertisement for a bursary. And the earliest period we could find was 1950. And by the way, after having searched, even the national libraries in Cape Town and Pretoria as well. And then there had not been a review of these policies really in other places. And then the policy is not well structured with using a framework. Academics often like some framework of some kind. For instance, the Jill and the Justin and Walt policy framework. That is the one that's commonly used when designing policies. The planning also not evidence-based. The need that is there to be addressed by the policy, not well defined. And then the implementation itself, the schemes were biased towards medical students and not the other allied, the other health professionals, such as allied. Poorly coordinated as well within the department itself, Department of Health, and also between different spheres of government. For instance, within government, the bursary might be offered by HRD or a bursary office that's often within HRD, Human Resource Development. But then when the individual returns, they will be placed in service by a different section of HR who do not necessarily communicate and have an understanding of the individuals who would have been funded, who need to be placed in service. The triggers or indicators of policy success not proactively stated. The service allocation in most instances was done after completion, and there was no planning when the individual was given the funding. How much in funding would be required to actually finance this person's salary? Because at the time they just planned for how much is available to fund this person through their studies for this period of time, but not thinking about the amount of money that will be consumed by this individual when they return to service. And as such, then you end up with individuals who are unemployed due to lack of of funds to pay the salaries once they return. And then some were, released from their obligations whilst they had a contract. But then at the same time, the unfairness part of this is that if an individual who has been funded defaults or rather leaves their contract, they are required to either reimburse a government pro rata for an amount of money that's agreed to with interest in often, for breaching their contract. But if government, on the other hand, says that I don't have a job for you, which is also another way of a breach. The government actually gets away with it because they don't have funding, they say, and then the individual then has to find a way of finding a job elsewhere. So that's part of the challenges. And then the cohort that we look at really, some provinces could not find the data at all, like the Free State struggled. The Eastern Cape, where I am, could only find data for those who were funded to study in Cuba. and not for all the others. But even those who started in Cuba, for those who started in Cuba, it's for only a number of years. KwaZulu-Natal, which is the biggest program in the country, could only find data for 347 individuals, could not find data for many years, about 6 of those years really. So a problem was really missing data in the quantitative study. As such, then, I mean, we could only look at defaulting from 3 of the provinces, including Eswatini. Botswana and Lesotho also have similar challenges as well in not finding, data that looks at individuals' compliance with the signed contract. And if you look at these graphs, for instance, I mean, what you would expect is that at the bare minimum, you would have an individual serving for a similar number of years, to the number of years that they were funded for. But here, in general, you find the individual has been funded for about 5 years, 50% of the individuals at least, funded for 5 years. But then that same 50% only serves 1.7 years, instead of at least the 5 years minimum that you would expect. Now, we further then look at, what then are the predictors or risk factors of defaulting. The biggest ones were really doing an internship and community service outside of the province of origin, which as we know, internship, you can do it anywhere. It doesn't have to be in the province where that funded you. But then that opens, other challenges, because even individuals end up being committed on that side, meeting spouses, finding the place attractive and being liked as well, seeing potential for them to specialize and settle there. Whereas community service, on the other hand, individuals are not supposed to be in a province outside their original province. That you would find then that individuals end up doing that. Which shows that there are loopholes in the whole system and its implementation. And as such, then, I mean, for every $100 spent, you'll find that about $48 is lost through defaulting. Again, it was impossible to determine the true cost of return of service schemes, which I forgot to mention. That when you look for the finances that were spent on individuals, asking government who funded this individual, they can't really find it because of the poor archiving as well. Again, in summary, loss of missing data, no data on the decision matrices could be found on how these individuals would have been funded, which you think is very important. Or should be important, at least for this policy, because they know the basis for which individuals should be funded or given a bursary, and you should be able to find it somewhere, but then you can't find it anywhere in the system. Now, I'll jump this in the interest of time. What we see is that really the current process looks at the shortages of skilled health professionals as in a linear fashion, Y equals MX plus C, and hoping that that will result in the increased pool of skilled health professionals by actually paying for individual studies. Automatically, you get a graduate skilled health professional who will serve the identified service area, and then that will then result in the increased pool. But the real world, unfortunately, is not like that. And I think this is one of the frameworks that actually emanates from that. It shows that this is a complex maze that needs to actually have 4 facets of planning, implementation, monitoring, and evaluation, which are very poor currently with the current bursary. And now when we look back to 2001, one of our foundational documents was the PEAK report, which had a number of terms of reference at the time. Just like now, we've got terms of reference for the panel that is reviewing policies. But that panel was there to look at, entry requirements for health professionals, for health professionals within the country, scope of practice of all health professional categories, review appropriateness of all categories, review the numbers of personnel being produced, ascertain the need for phasing out existing categories, explore new categories of health professionals to be created, review education and training, relate current resources and projected needs. And it's said then that, what is highlighted in green is what brings us here to have this discussion today. Now, another recent example is one that we worked on as recent as 2020. There's actually even another publication that we've just had now, but it was for Southeast Asia though. But then this one, we look at 3 countries, South Africa, India, and Peru. And we look at, the workload indicators of staffing needs. Some of you might know, that, there are a number of ways that you use to plan for health professionals. I'll just jump through this. These are the countries where we did it. The most common method is the population ratio method. That looks really, this is the number of individuals in the population, and then you need X number of doctors for that population. Assesses really the number of health workforce per category, where doctors, nurses, and so on. Now, the assumptions are that all populations, or rather population health needs are similar and constant, which we know is not true, just in the same way that it also assumes that professions of the same category will have the same competencies and workload as long as they are in that profession. So the workload indicator of staffing need, often referred to as WISEN, is a tool that is used to then determine the number of the health workforce, and it takes into account, the service needs, whether it's in a surgical ward or whether it's in a given community. It could look at, the needs for physiotherapy. It could look at the need for occupational therapy. It could look at the needs for medical doctors in a theater, given the data that is given by that service area. Now, the advantage of that really is that it considers the complexities of that service delivery platform. But then the challenge is that South Africa implemented that WISEN and assessed for all primary care facilities in the country. And then sadly, government got the numbers that were required and realized that they could not afford the salaries that are required to actually fund those numbers determined by WISEN. That was then abandoned and could not then be determined even for the next levels, hospitals that would be. Now, the challenge is that you've already spent money as government undertaking these studies. It's a lot of money, by the way, to actually undertake these studies. And then you're not even going to attempt to phase in this particular implementation, to look at how long it will take you to actually implement these suggestions. Obviously, it changes with time, but at least get there in a number of years. That was not even done, and then it was abandoned as such, which is for me unfortunate, and that is where we are, unfortunately. Now, another example, having conversed with an oncologist who left the public sector. I asked, why did you leave the public sector? The reasons are that, it's frustrating for me as an oncologist because patients delay getting to me because colleagues on the lower levels do not understand that there is a need, to refer to me as an oncologist. And then such patients present in late stages. All I can do is to just palliate these patients. And then at the same time, we overworked with long waiting times. And then some medications that are life-saving are not there in the public sector. So for me and my sanity, I had to leave the public sector. Now, you understand what commuted overtime is, but the long and short of it is that commuted overtime arises out of need for 24-hour service coverage. And unfortunately, in our setting, it's often linked to remuneration and money. which I believe is unfortunate. Mainly that arises because it has created a dependency where about 53% of that person's basic salary comes from it. So then it makes it look as if it's actually top up to your salary, or rather not even top up, it's actually part of your salary. Not realizing that it's actually an allowance that can be taken away at any time. And it arises out of a need. And then there are the 4 groups described that colleagues generally understand. Colleagues generally would hover around group 3 and group 4 of commuted overtime. But then the question then is the removal of commuted overtime a solution to the current challenges? Evidence suggests that commuted overtime is poorly managed. But then at the same time, overtime, not commuted overtime this time around, overtime in general, are not said to be high, including even in administration and nursing colleges, which raises questions. Provinces have also not been able to fill vacant posts. We've been struggling, as provinces for the past 2-3 years, to fill some of the vacant posts that are funded, not just medical as well. To some instances as well, provinces have underspent their human resource for health budget, which raises concerns. But for some of us who were part of the OSD negotiations, remember there was something called scarce skill allowance. That was removed. And then that was removed at the same time, in a way strategically, as part of the negotiations for the OSD, combined with the overall salary, to say, well, this is really included in the overall salary total cost to employer. But now then, when we move to the next other policies, Rural Allowance, RWOPS, including commuted overtime policies, it's then important for care to be taken when that is done, and it should not just be an exercise to save costs, but rather to make sure that there's efficiency in the entire system and patients do not suffer in the process. As highlighted by Rennefeld in 2020, one of the biggest challenges that we have is poor governance within our entire system. As you might remember, the health system building blocks, that really requires 3 things: capable stewardship, appropriate mix of technical and administrative skills, explicit political support. And then for all these, we realize that it's important to then identify and eliminate waste in the health system. And then look at, how can we actually remove the waste that is there in the system? But at the same time, look at what the needs of our population are in terms of health needs, which unfortunately most of these discussions do not look at. Often they look at monies that are not coming through from Treasury, but not looking at the fact that some patients have to wait for 3 days. In the Eastern Cape, sometimes patients travel for 5 days to actually get care, from their homes of origin. WHO also looked at some of these and had 5 principles really for an African health workforce investment charter. Improve leadership and stewardship. Health workforce planning should be evidence informed. Ensure that there are current HRS strategies. Stimulate more and better investments into the health workforce. Foster sustainability of the health workforce. Some of us might relate and remember these phones, the Nokia 1100 and Nokia 1110. Now, these are said to be the all-time selling phones, but unfortunately, what happened is that Nokia never anticipated that they could be toppled. They were complacent. They never then looked at how to actually outsmart the competition, but at the same time, other strategies that will make them efficient and relevant for the time. In the same way then, these are the mistakes we should never make. with our policies, we now have a chance and opportunity to do things right. Look at the entire platform and all these policies and take time. I would argue and say that try and continue the way things are going at the moment, but at the same time acknowledging that things do need to change and be done efficiently and improve the management where it needs to be improved. Ensure that there's a clear understanding of what the needs, demands are, what you call a labor market analysis for health workforce. What is the supply? What are the needs? What are the training needs as well that the country has? And then see how we can actually face in if the suspicion is that at least we've got a shortage of health workers of various categories. And that requires a lot of funding, and that requires an increased, expanded training platform as well. That unfortunately will not just be addressed by simply looking at 4 policies that will be removed, but rather review those policies and see how you can actually implement them efficiently. Or even if those that not work, yes, review them to actually remove them. But then at the same time, know that it's not a one-size-fits-all. There are still places that are too remote and rural that need to be accommodated, which is why it will actually take a lot of time if you do a thorough job to understand the landscape that South Africa has and how these policies can actually, what policies can inform better planning for human resource for health in this country. And then never lose then a curious mind. A knowledgeable curious mind is the breeding ground for ideas. That for me is very important as we really look at this. How can we actually have our health system be a health system that is one, appreciated and can be used by every single person regardless of class, and that can actually have universal health coverage implemented to make sure that the most needy person in the country can be actually able to access the highest quality of care that they need when they need it. And not just for the media and for me, because I can bypass the queue and get the needed care I need often because colleagues know me. But then that is not the same for every other person. I thank you and sorry for taking long.
Thank you so much, Prof. That was a great presentation. And we are indeed better informed at this point than we were before the presentation. We have in the panel Dr. Luvuyo Bayeni, who is a director, Human Resources for Health Director in the National Department of Health. He's a medical doctor himself, and so went through all these policies first as an implementer, or as a medical doctor in clinical practice, and then later on, being in charge of the policies themselves. We also have Dr. Dwayne Blow, who himself is a medical doctor and also an academic dealing with human resources for health. He has extensive experience working in the human resources for health strategy space, and also has developed or minted some excellent PhDs, some of whom I've had the privilege to meet. So I will give our 2 panelists the first step at asking some questions to Prof. Mabunda, so that we can elicit more insights into the work that he has done and the presentation that he just made. So maybe I'll start off with Dr. Dwayne, Dr. Dwayne Blow. Any questions for Prof. Mabunda?
Good evening, everybody. So I'm not sure if I have any questions, but maybe some comments on this topic that I can relate. So I'm a public health medicine specialist, and I work at the Center for Health Policy at Wits University. And as you mentioned, I work mostly in research on human resources for health from a sort of economic perspective, and also have a current research on dual practice and RWOPS, which I think is how we came into contact. But relevant to the topic of the seminar, which really relates to HRH planning and staffing, I was also involved, part of the Ministerial Advisory Committee on the 2030 National HRH Strategy, and I was the technical lead on the work stream 1, which was really trying to understand something about the needs and costs of the health workforce in South Africa. So I'm going to reflect a little bit on that process and taking forward the discussion from Professor Mabunda's presentation. I mean, I think firstly, I wanted to say that to define perhaps the topic for this discussion is that there's sort of two related questions. One is how many doctors do we need in South Africa? And the second one is how many doctors do we need to fulfill the public service requirements in the public service? And those are sort of connected questions, but the one is a bit more difficult than the other. And partly the problem in South Africa is we do have this very strong dual health system with the private sector. So whenever you're trying to think about human resources for health, you have to think about the labor market as a whole. And that means why people choose to work in the public sector and why they don't work in the private sector, and the sort of remuneration and other opportunities between the two sectors. So we really have to understand the whole labor market, particularly for doctors. And that's quite complicated. It's a little bit easier perhaps to try and work out how many doctors we might need for the public sector than how many doctors we need for the country as a whole. But as I think we found in the HRH strategy, that's also not a very simple question. At the moment, given the fact that people are talking about the shortage of posts in the public sector, and that implies that we have a demand problem rather than a supply problem. In other words, if there were posts, people would want to work there and they'd be able to work there. But the problem actually is that we don't have enough demand from the National Health Department in terms of public sector posts available. So based on that, the question is rather, do we have enough posts in the public sector for meeting the needs of public service, rather than really do we have enough doctors in the country? And so I think that's a common problem in many HRH strategies around the world. You're saying we need more doctors, but what you really need is more government money to fund posts. Often the health workers exist and they would accept the posts, but the government doesn't have money to employ them. So that's a different problem. Although we do have this private sector, I think the other important thing is that the market for doctors is very regulated in South Africa, both in terms of supply and constraints on where people can work. So we don't have private medical schools, we only have public medical schools. So that means the number and distribution of training posts is highly regulated. And in terms of where people can work, quite a lot of the people working in the public sector do that because they're forced to do so. They're interns, the community service because of legislative requirements, or registrars who are in training. And then that's because in South Africa, you can only train as a specialist in the public sector, and many people do want to specialize, so they work in the public sector. But of course, they leave quite soon after that for the private sector. But to get back to this question of how do we plan how many doctors we need, I think that's something that we try to look at in the HRH strategy. Professor Mabunda has mentioned some of the approaches, the population-based strategies, WISE, and there's been some experience with those in South Africa. The PIC report is a sort of population-based model, but getting quite old now. And as Professor Mabunda discussed, the sort of WISE experiment, primarily for primary care, didn't really result in significant actual implemented workforce planning. But there have also been other strategies in provinces and other things to work out how many doctors they should need. And clearly we need a more complicated model that is based on population, but also burden of disease in South Africa and the sort of service delivery models and utilization, and all of that needs to come together into a sort of complicated health workforce planning model. But the reality is that I think, as we know, the current planning model is based mostly on historical posts and budgets rather than some sort of rational planning model. I mean, so there are three things that I want to emphasize from the HRH strategy in terms of the work we try to do there. Simple points. The first one is that at the moment, public sector posts are not keeping up with demographic changes. So the population is increasing, which we mean that you would expect the number of posts to increase, even if a simple population-based model. But that's not happening. So we're in fact decreasing our ratios because we're not able to maintain the sort of increase to meet population levels. And part of that difficulty is that doctor salaries are quite high and they increase every year. So in fact, you actually can employ fewer and fewer doctors with a sort of constrained or the strained but staying budget. The second point we made in that report was the sort of significant inequalities between provinces. So the ratios are very different between the Western Cape and Gauteng and then Limpopo and Eastern Cape, for example. I mean, for fairly obvious reasons in terms of the location of resources and also where people want to work. But it's not very easy. We did a modeling exercise to calculate how much it would cost, and it's a very expensive exercise to try and achieve something near the middle in terms of equity. And even if you gave extra money and extra posts to more remote provinces, it's not certain that they would be able to fill them. Doctors don't really want to go and work in Limpopo or Eastern Cape. And so you may give them more budgets, but they wouldn't actually be able to spend that increased budget because it's not easy to absorb significant changes in your budget. And I think the third main argument that we made in that chapter that was important is that we need a better health workforce planning in the national department, and that means we need more capacity and we need much better human resources for health information systems. And unfortunately, that sort of suggestion has been made in every single HRH strategy that we've developed for the country, and we still don't really have a strong, dedicated, skilled unit in the national department with the required information to be able to do proper workforce planning. I think if we were able to do that, I think most plans would say that we needed many more doctors in the public sector than we currently have. But part of the problem, I think as we all know, is that requirement, and that's partly what happened with Wizen, is we do these detailed models, we work out that actually we need 5 times the number of doctors than we currently have, or nurses. But that has to be balanced against this fairly hard reality of static or declining health budgets in government. And I know there are many arguments that we can find more money. We reduced funds lost due to corruption and misappropriated expenditure and inefficient procurement, and then there's always this disturbing thing of unspent budgets in various government departments, including the departments of health, and all that money could be utilized better. But overall, it seems unlikely that we're ever going to really be able to. We're not going to be able to significantly increase the posts in the public sector, particularly since of the additional 1,200 doctor posts that were announced in April this year. So that means we sort of have to work out how to do better with what we have. And I think that partly prompts this sort of national department focus on trying to revisit some of the HRH policies in the country. I mean, the two points I wanted to make here just about that are quite critical to working out how many doctors we need, and those are two sort of system level issues. The first is sort of discussion about skills mix. To be more efficient, you could use a more efficient mixture of health workers in terms of different categories. Nurses can maybe perform some jobs, and they do that in the primary care sector, of course, predominantly a nurse-based model of care. although NHI proposals are about changing some of that, or clinical associates or mid-level workers. And so that is an important consideration in terms of trying to be more efficient, is the appropriate use of different categories of health workers, but also about the distribution between different categories of doctors. Quite a lot of the workload in public sector facilities and hospitals is borne by junior doctors. And the sort of balance between different types of doctors is also important in terms of efficiency. And my second comment is just about productivity. So although we spend quite a lot of money on the health workforce budget, some doctors work very hard, but others, in particular the junior doctors, are working extremely hard. But other doctors are not. That's not necessarily true for all doctors. So and policies such as RWOPS have been quite important in thinking through the sort of impact of public sector productivity, which are important. And so there is an important consideration about whether or not the health system is getting value for money for all the health workers currently employed, which will obviously be one of the questions in these review panels. I think my just quick final comments on commuted overtime, because that's where Professor Mabunda left off, and that's obviously a hot topic at the moment in terms of the Ministerial Advisory Committee and for SAMA. So some just final comments. Firstly, I think it's not possible to stop commuted overtime. Obviously, commuted overtime is the model that we currently have to provide services at night and over weekends. And so it's an important part of how doctor care is organized at the moment. And the second thing is that there's not actually a lot of academic research and literature on the topic of overtime. There's a very big literature on the fact that junior doctors are overworked, mostly from high-income countries, interns and registrars in particular, working many, many hours, much more than is good for patient care. And so many countries have implemented constraints on the total number of hours that doctors can work, either per week or per shift. We don't have those specifically, but there's very little literature on how to organize this overtime function and pay for it. That's most countries in the world seem to follow a similar model to South Africa, where you actually rely on existing personnel working overtime to cover duties at night or over the weekend. A few countries use a sort of more shift system where you actually employ separate people or you have different shifts to cover that workload, but that's a bit more unusual for doctors. Although, as we know, it's the model for which how nursing care is organized. But that would have a big impact on staffing, is that if you change to such a model, you would have to increase the total number of staff. And then just finally, I think that that doesn't mean we don't need to relook at the overtime system. I think that's an important point, and Prof. Mabunda mentioned that we need to be looking at the sort of revisiting that policy carefully, thinking as an employer rather than employee. The question is the system efficient and fair? And one weakness that we have is that we have this system of where we pay in bands and we don't pay people for actual hours worked or shifts worked. It's not clear what would happen if we move to such a system. Would it cost more money or cost less money? But that's an important academic question. Certainly, lots of doctors are working more than their committed contracted hours, but quite a lot of doctors are working less. And then, of course, the other key question is whether or not you pay the same for people working on site or people off site. And that's also one of the questions that will be considered by the advisory committee. That's all from me.
Thank you so much, Dr. Blow. Those were very extensive comments and very insightful. Maybe at this point we will ask for Dr. Bayene's comments before we get on to Dr. Moketsi. Dr. Moketsi is a cardiologist by profession. He's also a head of department in cardiology, and so will be important in giving us the perspective of HODs in the determination of working hours. But before we get to Dr. Moketsi, Dr. Bayene, any comments from your office as to the discussions relating to the working hours, the presentation from Prof. Mabunda, as well as the insights from Dr. Blow.
Thank you very much, and greetings to the colleagues, and thank you for the opportunity. I can confirm that I think I was enjoying the conversation from the presentation from Prof, as well as the comments that were just made now by Dr. D. The first one for me is, as a department and maybe as a portfolio in terms of human resources for health, our approach is probably a different approach in the sense that we are very much interested in what the stakeholders can guide us on how to go ahead on certain things. The reality is that policies by their nature, they cannot withstand the turn of times, and at some stage they would need to be reviewed, whether for improvement, whether for change, or even whether for the absolute cancellation thereof, depending on what the circumstances of the day are. And that's a space that we must agree that we find ourselves in. It's so embarrassing and sad that most of our policies date as back as, if they were reviewed, it would be 2015, 2016. And there are those that have not been reviewed even at that time, so which gives them even a longer time span. And by virtue, 10 years later, we cannot expect that they would serve the same purpose. And then I think that's the space that I would just like to be upfront with in terms of the membership of SAMA, but as well as the organizational leadership as well. To say that we are in that space, and equally so for me, I take it as an opportunity for all of us, especially those that are equally affected now and feel the pain or the pinch, so to speak, that let's make use of this opportunity and see how we then inform the reforms and how we inform the change, but also how we shape the future in terms of what can be done. Of course, this is not only about us as individuals and as the medics, but also our contribution in terms of health system strengthening. How do we go about it? What is it that we can do? How can we achieve? It is true that even from the presentation, there are principles that are global in nature, but equally so we have tried in South Africa, the return on service, but the reality is we've got an experience that we need to review and see. Does it still serve? Is it working? Has it worked? And how can we improve on it? And how do we go around improving that? And I can confirm, colleagues, that even the issue of planning, it's a serious issue on our part. Hence, it was mentioned as well by Dr. D that if you look at the HRH strategy, which was signed off and implemented in 2020, it's now halfway through the timeline. It's 5 years, but we are acknowledging that maybe some of its elements might not even make any difference or take us to 2030 as envisaged. Hence, we are currently doing a review of the strategy, and we are getting some support that we're going to get from the Department of Monitoring and Evaluation, Performance Monitoring and Evaluation. So we are at a space where we would also need those inputs. We have accepted and seen the criticism that even in its own nature and current form, there are areas that it had not covered in terms of the expression of where do we want to go. So we need to bring all our heads together and see how we can improve. Yes, there is a Ministerial Advisory Committee, which we are openly inviting SAMA to make sure that they don't miss the opportunity to represent the membership, but to represent the profession as well, in terms of what is it that we need to be saying to the advisory committee, those facts that we have, those realities that we have lived, and those fears that we know are a threat to the profession and the service delivery. So that is our opportunity now to make sure that we input and we share and try and find a way of making a difference. We have noticed, and we still welcome, especially those members that are based in Limpopo, for instance. We have not been able to make a comment or an opinion because we don't have something that we have received that will be helping us from those that are affected by the shift system. And for us administratively, I think Dr. D mentioned that sometimes we look at administrative efforts to try and make use of what we have. So we might be sitting in a premise that says that was the intention, and we could be convincing ourselves that was the solution, but yet you would find that the members on the ground or the affected professionals are having an opinion that is far much different from that. And we would welcome those inputs so that we do not get to move. And I think we've also expressed to the likes of Professor Skhumbuzo to say, maybe if we also need to have an academic angle to that, let's start doing that. This is our time, this is our chance, let's work together. And let's make sure that at least we don't miss this opportunity. Thanks. I'll be looking forward to the discussions. Thank you.
Thank you. Thank you so much, Dr. Bayeni. That was very insightful. And I do like that you're inviting us to come through with our insights, because colleagues, we have a survey, a poll that's running. Please do respond. The inputs from that poll will be going straight to Dr. Bayeni's office and to the MAC. So please take your time to fill in that survey. And then thank you, Dr. Bayeni. So we'll move on to Dr. Mwaketse, who I introduced before. And Dr. Mwaketse, you're an HOD. You've seen a lot through your time as an intern. ComServe. You've been a medical officer, a registrar, and now you've reached the top of medical practices as a cardiologist. One of the main questions that is showing up from the colleagues is what's the recommended number of working hours that would guarantee patient safety, and what safeguards can we put to ensure that happens under our current circumstances? Thank you. So I think it would help if you addressed us with that. Thank you.
Got it. Thank you very much. Firstly, I just want to greet our colleagues from across the country: KZN, Gauteng, Northern Cape, Free State, Limpopo, Eastern Cape, etc., etc. So I think one of the things that we need to realize is that this is a very sensitive issue. It's a very important matter. And I just want to cut to the chase so that we speak about the elephant in the room. In the Eastern Cape, as it stands, we only have one full state cardiologist for the entire province, which is over 4 million, give or take, people. So in Port Elizabeth, East London, only Umtata, we've got full-time cardiologists. If you go to Limpopo, it's the same thing. Some provinces do not have a full-time cardiologist. In the Eastern Cape, we've got 2 full-time rheumatologists in the state sector. So these policies, we need to take into account that a lot of the things that we're talking about, we're not talking about Joburg. We're not talking about Cape Town. Oh, sorry, I've got flu. Sorry about that. So a lot of the things that we are talking about do not cut across all the province in the same way. And I think it's something that we need to really, really think about. The second thing I want to talk about is the issue of, I'm not trying to be pedantic or fussy. My colleagues in private, they earn 4 times more what I earn. I mean, I'm sorry for talking about salaries, but a HOD in the state sector will take home 150,000. My colleagues take close to $1 million a month. And these are the things, and you need to filter in the work that we're doing. We need to do government work. We need to do clinics. We need to do ward rounds. We need to do calls. We need to go to the university. We need to teach undergrads. We need to do end of block exams. We need to do post-grad exams. We need to go teach masters. We need to supervise masters. We need to mark masters in our institution and mark masters from other institutions. We need to do PhD supervision, mark. I mean, and then on top of that, there's meetings in the hospitals. I mean, these things are very intensive. And for me, I think it's very important that if we're going to do policy implementation, it's very important we consider those issues. And I don't want to be long so that we miss the crucial issue that I want to send across. So some of these don't make sense. I mean, we've got nephrologists who, a colleague of mine, we trained together in Cape Town, Dr. Mangena, for example. I mean, literally on call every other day. Be it on the phone with your family, friends, you with your wife, you're out, you just have to take calls, interruption. So the whole thing of 8 hours doesn't make sense. You're there almost every day. So I think it's very important that the things that inform policy speak to what's really happening on the ground. And what happened in Pretoria and other hospitals where harsh policies were implemented, people went to private. Be it anesthesia, cardiothoracic surgery, cardiology, etc., etc. So we don't want an exodus of specialists going to private because we're making irrational policies that are only going to hurt our people. And sadly, these policies will hurt the people that are poor. And the rich will continue to get better services, better treatment, and better supervision and care. And for me, I think that's very important. I think for now, I'll end there, and I'm willing to take comments. And I thank all the colleagues across the country that have taken time to join. I see there's over 200 colleagues that have joined in, and thank you.
Thank you, Dr. Mwaketsi. Yes, and it's remarkable the passion that you show for the work that you do, and the passion that you have for your patients. I think for me, it's a lot telling. We've had to speak about how there needs to be due consideration when salaries for doctors are being discussed, because doctors are not inherently and entirely people who are passionate purely about their lifestyles, but the greater part of the passion comes from seeing patients get better, being able to take care of the poorest of our patients, and it's remarkable how you are able to demonstrate that even in the discussion. I think I will have, because we're almost out of time, a question that will go to Prof. Mabunda to say, you did mention that it will not be a good idea to remove any of these policies abruptly. What safeguards do you think would be necessary, and what practical safeguards do you think would be necessary should anyone consider to remove some of these policies? And to put the question into context, you know, the minister has mentioned removing some of the policies, and there have been, you know, discussions, corridor discussions about others, and as well to what Dr. Moketse just put forward. We did experience in Gauteng a very stringent, you know, change that was being proposed by the Gauteng Department of Health. So what safeguards do you think are essential then in ensuring that we don't have a mass exodus of doctors who are in extremely short supply in the public sector, then opting to go private? Thank you.
Thank you, Dr. Ngcobe. You know, it's a very difficult question to respond to. What I said earlier, yes, you can't remove them abruptly. The most important thing, firstly, maybe before responding directly to a question, would be to ensure that, I mean, maybe to state upfront that I'm happy with the task team that is looking at this. I mean, I've got wisdom that this task team will really advise the minister correctly, at least on what needs to be done. You know, and part of which is really to say, let us take our time as a country and do things right. Look at all the literature that are there, yes, but then be inclusive in who is going to assist us. Let's get as much technical support and assistance as possible from within the country and elsewhere. Because we've got lots of academic minds who can be able to, you know, who have worked in this area to really increase the capacity of the task team itself, and assisting it to us to advise the minister correctly and make the best recommendations for the country for the long haul, and not just, you know, to satisfy a regime or, you know, a narrative of some kind. But at the same time, even, you know, making sure that our patients do not suffer, and we plan for, you know, we have inputs into the National Health Insurance Act that was introduced. So then what the safeguards are then, more than anything, it is to ensure that the job is done correctly, which I have wisdom in, that is going to be done, at least by the task team, in advising the minister correctly, and taking time to actually get it implemented, than actually to rush the process altogether. Because then, for me, suggesting, you know, what I could speculate, you know, as, or rather look at, because this has never been done. We've never been here at this point before. And now, I mean, the world has opened up after COVID, where high-income countries are now looking for our health professionals. We know that our health professionals themselves are aging as well. If you look at labor market analysis, it's clear that our nursing profession is aging. It's clear that our medical professionals are also aging as well, as much as we're training, but we're not training enough as well. So we need to then ensure that, you know, that is, well, at least I've got wisdom in the panel that has been selected by the minister to advise the minister correctly that we need to take time in doing the correct thing. That is the only safeguard I have.
Okay, thank you. Thank you so much, Prof. Mabunda. I think I'll give Dr. Bayeni 2 minutes to or a minute to just have his final remarks, and then another minute will go to to Dr. Blow, as well as to Dr. Mokete, just 1 minute each, because we finish in 5 minutes. Thank you.
Thank you very much, colleagues, and I appreciate the discussions and the inputs. And also for me is to say, as the department, we rely on your inputs more than anything else. I think we would not want to be part of a system that will impose, a system that will ignore realities, but rather we want to collectively with yourselves to be part of those that influence and change the system for the better, with us contributing as a collective, all of us. And as we had said, colleagues, it's about us trying to find ways of thinking outside the box. What is it that we think will work? How do we ensure that not only patients are safe, but also us as the professionals, either mentally, physically, and otherwise, and not find ourselves being in pains, as much as it was not intentional, but sometimes you need to be humane, and you can tell the pains with which Khulile has been observing and is working under. And that's not what we want for our healthcare workers. And we need to come up with solutions that can try and meet us. Yes, it might not be complete turnaround, but let's meet each other halfway and see how we can improve things.
Okay, thank you. Thank you so much, Dr. Bayeni. Dr. D, a minute.
Okay, there have been lots of topics and there are quite a lot of questions and comments in the Q&A, which I don't think we've adequately addressed. But maybe to reflect on some of those, I think one of the difficulties that needs to be thought about quite a lot is that we have very particular problems with certain categories of doctors, and we need to pay more emphasis to that, like subspecialties and specialists in general, and certainly in certain provinces. There's quite a lot of the comments and questions in the Q&A reflect that. And one of the difficulties, I think, in all these policies is that we've had a very sort of we're trying to treat all public sector workers the same. So we have policies that really apply to the entire public sector. Whereas really we need to recognize that there's a significant crisis for particular categories of health professionals and particular categories of doctors. And we really need strategies that are maybe slightly more targeted at really addressing those needs rather than trying to solve the problem of sort of doctors in general. And that means sometimes we might need differentiated policies for different categories of workers, even though health workers and the government doesn't quite like that idea of having sort of unequal focus on certain categories. But I think there's a significant crisis for highly specialized specialists and subspecialists in the public sector that's really important to begin addressing to improve broader quality and morale of junior doctors as well.
Oh, thank you so much, and I think it's a vote of confidence in SAMA for the way we've categorized our committees and the doctors within our committees. Thank you, and then Dr. Mokete, your parting shots in a minute.
No, thank you very much. Look, I think for me, let's like I said even earlier on, cutting to the chase. State specialists work extremely hard, and the remuneration that we get compared to our colleagues in private. I mean, I'll just make a quick comment. I hope this will ring in the bell in most of our colleagues when they're chilling on their own. So in the working room, the guy comes and says, "I'm leaving state. I make the money that I make in private within a week. What's the point of staying in state?" It's something that I hope when colleagues leave, think about it. I have 2 colleagues, an orthopedic surgeon and the physicians who have left to private. We need to think about this clearly whenever we form policy that's going to hurt our state patients. And again, the poor of the poorest. are heavily affected. Thank you.
Thank you so much. Thank you so much, Dr. Moketsi. And I'd like to really, pass a special message of gratitude to our panelists who have done an amazing job and have enlightened us. Behind the scenes, we've had Renir, we've had Nelene, we've had Zianda, Claude, and the team at Professional Affairs. And we'd also like to thank our leadership, the CEO, the vice chair, and the chair of the organization for all the support. And please do fill in the poll so that we're able to send that message, your voice, to the Ministerial Advisory Committee and to Department of Health in the shaping of these policies. Thank you so much and have a great night.
Thank you.